Hello, and welcome to Say Yes to NMES. I'm your host, Craig Mateer. Today I'll be joined by John Kelly, one of the VitalStim DyNES instructors. We talk about a whole range of NMES topics, and I hope you'll enjoy. Why don't you start by telling me a little bit about yourself and your background as a therapist?
So my name is John Kelly, and I'm a physical therapist in Chattanooga, Tennessee. I've been a therapist for almost 25 years, and I graduated from University of Florida with a degree in exercise physiology, and worked for a year or two, and strongly encouraged by some colleagues to try to look into getting into physical therapy. So I applied and was accepted to University of St. Augustine. So back then and that school is very orthopedic, but I was really interested in the neurological patient. So I finished there and wanted to work inpatient rehab, and that's what brought me to Chattanooga. So I have been a physical therapist, both inpatient and now I've been outpatient for maybe 12 years.
And what type of facility do you work at?
It's an off-site hospital-based practice, and we have all disciplines. We have on-site occupational therapy, physical therapy, and speech pathology, but also have access to psychology services downtown at the main hospital.
And how did you get started with VitalStim?
Yeah, no, there's an interesting story. So the gentleman that hired me out of school was one of the authors of the VitalStim course. And his name's Ulrich Whiting, and Ulrich said, hey, I met this interesting woman who is a speech pathologist, and she's been using NMES on the throat for swallowing muscles, which to me is it's skeletal muscle like everywhere else, so it didn't really phase me, other than it's not a place I usually treat. And there's, as long as it's safe to use on the throat from a baroreceptor reflex and a laryngospasm, which apparently she was having good results. It really didn't. I didn't think too much about it, other than that's an interesting way to use NMES. And Ulrich, when I went into his office, he had and we're in the midst of kind of organizing and putting together a fairly comprehensive outpatient spinal program, rehab program. And he has an oropharynx drawn on his dry erase board, and explains to me he met Marcy. And that's how I sort of got involved in the very beginning on the coursework that he was interested in putting together, and the team he wanted to teach the class to speech pathologists.
And how long have you been teaching the VitalStim course with Chow?
So that's probably been since, I want to say it started around 2003. So a year or two after that, or maybe even like 2003. I'm not exactly sure, but quite a long time.
And for those that don't know, the VitalStim course actually has two instructors. One that's a dysphagia expert, typically an SLP, sometimes an OT, and then one that's a modality expert, which is often a PT, which is your role, correct?
Correct.
What perspective do you think, as a PT, you can say about NMES, specifically in the treatment of dysphagia?
Yeah, that's it's been I mean, in the beginning, I am the modalities person and don't take a primary role in instructing the dysphagia segment of the course. So for me, in the beginning, I didn't really understand the process of evaluating a video fluoroscopy or looking at manometry or any evaluation tools that you would use at bedside to come up with a treatment plan. So I used to say larynx, and now I say larynx, and I understand all the neuroanatomy and the anatomy and the biomechanics of the swallow. So I think I might have even lost my train of thought there with your question.
What perspective as a PT do you bring to NMES?
It's pretty straightforward. It's not it's not that you're doing anything fantastically different than a PT or an OT would do anywhere else in the body. You're providing an external stimulus with just a couple of AA batteries to what we call is depolarize or influence the nerve that innervates the muscle. So you can use an external muscle device, contraction device, to get the nerve to fire, and then you get a muscle to contract. But it doesn't by itself help you swallow any better. That's the role of the therapist. That's the expert in managing what you're eating, how you're eating it, and the viscosity, the texture, the temperature, everything that has to do with what is in the speech pathologist world, the resistance to the muscles that you're trying to condition. So you're just engaging the muscles with an external stimulator and having a stronger training effect.
And all the Chow PT instructors become, I guess they get their SLP, I wouldn't say wings, but they certainly get exposed to the to that side of the treatment regimen, and you seem to have really found that very interesting and seem to expand the things that you've been doing based on that exposure. Would that be an accurate statement?
Oh yeah, there's I didn't know what I didn't know, and even thinking I'm multidisciplinary in my approach to a neurological patient, clearly that wasn't the case. And I don't even, maybe 8 years, I'm not exactly sure how many years into it, my question to the speech pathologist was, if you're working really hard to educate a swallow that's neuromuscular electrical stimulation, that is not just therapeutic exercise, and you need to stretch connective tissue, you need to stretch muscles, you need to work on your endurance, on your posture, on your respiratory status, encouraging better costal mobility. There's so much that the physical therapist, who really doesn't know, I mean, it might be a referral that you get from an attending physician that wants you to get involved in managing the neurological patient, but we just think about it as, well, we're just going to train gait or make their balance better. But really, if it is a multidisciplinary patient, you need to be involved in all the aspects of treating that patient. And there's a whole lot to offer from a manual care, exercise, endurance perspective to that dysphagia patient. And I really just, it wasn't until I started really teaching that class that like I said, I was the modalities instructor. But now I become kind of, over the years, and I've known you, Craig, for a long time, and Leslie, and over the years, my practice has kind of moved, and that's what a physical therapist does, works with a SI joint in the pelvis and the low back. But now my practice kind of comes above the clavicles. So I'm very interested in dysphagia. I'm interested in dysphonia, muscle tension dysphonia. I'm interested in vestibular problems, cervicalgia, headaches, everything that's sort of above the clavicles, which is a career by itself, actually.
Yeah, that's so cool. I'm not a therapist by trade, so my background is engineering. So I always find this so interesting. But basically, you're trying to help the SLP think about all those things around the muscles they're working on from a PT standpoint that SLPs probably wouldn't think about, and PTs wouldn't think about trying to help. Am I saying that correctly?
Yeah, that's exactly right. I maybe the SLPs intuitively know that things need to get done. For example, if you're working on retention in the piriforms, and you know that pharyngeal compression and hyolaryngeal excursion are going to help you clear the distal pharynx. Of course, you need a pharynx that PES that opens, so there might be some medical intervention. But there's a lot that the physical therapist can do to help manage that soft tissue. And since I've gotten involved with the NMES class, the VitalStim class, I really seek out those clients, and people that I work with know that there's some work to do in preparation, say with a head and neck cancer patient, that there's so much connective tissue restriction that it wouldn't matter how hard you work on strength. There's no mobility to the hyolaryngeal skeleton. So that would probably come first. And I have 2 patients on my caseload right now that I'm prepping until probably maybe 2 or 3 weeks to manage some soft tissue before they start with the ST with their dysphagia intervention. So it's been a bit of a long road for me, but I think from both sides of it, either side doesn't know what they don't know, and the dysphagia patient can certainly benefit from a team approach.
And that's led to several courses that you do for child seminars. Let's talk about the first one that you started with, and that was your myofascial course. What is that about, and how does that help the SLP?
That's any other profession would clear the mechanicals before they started training the neuromuscular. And muscles get tight. They're just long chains of protein that slide along each other. And if there's adhesions in the muscle, that's going to restrict your flexibility. Plus, it's also a driver for a reflexive contraction, because it's kind of set itself at a new baseline, the nervous system. So the muscles are a little more, let's say, hyperactive, but they're more sensitive to elongating. And connective tissue, if you leave it sit for a while and you don't have a good muscle pump, you have fluid stasis, and you have tightness in connective tissue, and all that will restrict flexibility. So the myofascial course seemed like a logical thing to want to add, and that's been pretty well received. And I've been teaching that for over 10 years now. So that's my contribution. And the speech pathologist, with these head and neck cancer patients, for example, they do need a lot more attention. So that could be a full session for me, working the shoulder girdle, the thoracic spine, the rib cage, the anterior neck, even down to the hip flexors that influence a deep breath with the diaphragm. So to answer your question, there's a lot of things you could do from a myofascial manual perspective to clear the mechanicals and make the job a little bit easier for the speech pathologist.
And in the course, obviously, you're not teaching an SLP to be a PT, but you are teaching them techniques that they are able to do to help their patient from a PT kind of perspective, correct?
Oh yeah, absolutely. So I like to teach the KISS principle in the class, the keep it simple kind of stupid thing, where you treat the major mechanical problems. And I want to use day 2 as treat the major postural issues, and the patient should benefit from that. So all the rib mobilizations, the diaphragm, the hip flexors, all that stuff, I can contribute from a postural perspective and a breathing perspective. But the speech pathologist should be able to manage the fascia and the hyolaryngeal skeleton and the anterior neck, everything anterior to the sternocleidomastoid, which would define the front of the neck from the back of the neck. It seems that the speech pathologist stops at the sternocleidomastoid, but just manages the strength issues and with exercise, managing a bolus. But the PT kind of stops at the sternocleidomastoid from posterior to anterior to the sternocleidomastoid to the lateral part of the shoulder, and don't come anterior to that, and don't understand the mechanics of that. So yeah, I think there's quite a bit that the speech pathologist can learn in a couple-day course to get good at the major stuff that's going to help the patient improve in their function. But I will add too, Craig, that something that I enjoy is dentition. A lot of these, and I just got interested in this because that's the head and neck cancer patient. They have extractions anticipating radiation therapy, and they're going to get weak with their jaw and lose their teeth, so or get infections. So understanding mastication and working with the tongue, and working with the cheek wall, how it communicates with the pharynx, because that's a fascial sleeve from the cheek to the pharynx. there's things that you can do in that class that I'm going to help you. Oh, I really hadn't thought about doing that, and I didn't realize the value of that. And sometimes when you feel it on yourself, you know now that I was missing something major. So that's all things that I cover in the 2-day class for the myofascial course.
That's awesome. And then that basically kind of led to another PT concept that you're bringing to the SLP, and that's a K-taping course for swallowing also, correct?
Yes. So just like in a physical therapist world or occupational therapist world, sensation drives motor control and function. So you can use some taping techniques on the face and on the anterior neck, and to help with posture and with breathing that could benefit your client too. So kinesiology taping is just a thin fabric, hypoallergenic tape that you can lightly put tension on and influence sensation. So yeah, that's a 1-day class that I think has got some valuable information, and it's something that physical therapists regularly practice with if they can't have their hands there 100% of the time. So there's always this sensory drive that the patient's feeling when the patient leaves my session of physical therapy, and maybe if there is facial paralysis and you want to tape the face for oral loss or for buccal tone, you can tape that, and the patient benefits from that, from leaving your session and coming back to the next session.
And again, that's using this PT kind of concept, but targeting dysphagia, which the SLP is working on.
Right. For the same reasons. We're all working with skeletal muscle and sensory drive. So there's an application for the function of swallowing, just like there would be for back pain or gait, or engaging the intercostals or the oblique muscles to help with breathing. There's that's an extra tool that you can use to make your session a little more meaningful.
And then because you're not doing enough already, you also attacked a question we get, Chow gets all the time, from our SLPs, which is, Bell's palsy, and what they can or can't do with that diagnosis. And so you have a course where you talk about that. Tell us a little bit about that one.
Yeah, I was encouraged by you guys to put pen to paper, and it's something that I treat in the clinic frequently. I don't know if I think my name just sort of got out there in the community that it is a peripheral nerve that can be entrapped either from edema as it exits the cranium or viral infection. So emergently, they're given medications to help with the swelling and an antiviral. And then if there's no immediate recovery, or I guess you call it sort of spontaneous recovery, then a referral is made to outpatient therapy services. So a combination of taping and manual therapy. The course is about Bell's palsy, but also facial palsies in general. So I do narrow things down from assessment of the facial nerve involvement, but to also discuss clinical etiologies for facial palsy, from acoustic neuromas to space-occupying lesions to viral infections. It was kind of interesting that I guess this will kind of date the discussion, but that Justin Bieber has a case of Ramsay-Hunt syndrome, and that's not an uncommon thing. I guess it's certainly uncommon to somebody reading an article that doesn't understand facial palsy or not, in the therapy world. But it's something that I see in the clinic, and I treat that facial palsy similar to Bell's palsy. So that course has actually been interesting for me, because there's always a question about, do I use NMES? Do I not use NMES on the facial nerve as it's recovering? How can I give support to the buccal wall? What are exercises that are appropriate to avoid synkinesis? So there's a lot of questions that I'm trying to answer in that class, and I don't want to say give hope to the patient, but there's more stuff that you can do from a therapy perspective to support that structure and encourage healing after an infection or a facial palsy presentation.
Well, I know I'm always impressed by your willingness to think outside of your box and bring your expertise to others. And I know the students that come to your classes think so too. Chow has a annual VitalStim provider conference coming up in August, and I think you're going to be doing at least one session, maybe more. Forgive me if I have it wrong, but tell me about what you have planned for that.
Yeah, so there's 3 classes. You might have to remind me because things got discombobulated and it was rescheduled. But there's an hour discussion on, I believe it's an hour discussion on NMES and the Bell's patient. Is it appropriate? Is it not appropriate? If you were to use it, what would be parameters that you would use and why would you do that? 2 was on taping. So kinesio taping for the swallow. And so I tried to present some taping techniques that would be the most maybe beneficial in the short term without having to go through. There's backgrounds to introduce the technique, of course, but I did want to do some labs. So the labs that would be effective for you in the clinic after you watch that hour session. What can you do on Monday to put that to practice? And then the last one, which is actually one of the more interesting ones to me, is working inside the mouth with fascial release, that you can not just mobilize the cheek wall, the lips, and the tongue, but how would you mobilize the tongue in particular, and what is the sensory drive for the palate, for the tongue, for the gum line, mastication through the periodontal membrane, how that facilitates secretions. I think that there's a lot of information kind of packed into that 1 hour session on soft tissue and the oral cavity. But I really enjoyed writing that one.
That's all awesome.
It's gonna be fun.
One of the goals of this podcast for me is to try to highlight the many, many, many success stories that NMES brings to dysphagia patients. And I know you're not treating dysphagia and per se, and I'm putting you on the spot a little bit because the SLPs that I bring on, I have a more direct question. But can you talk about a success story that you feel like NMES was involved in a patient of yours that maybe you led up to that or anything like that? If not,
I can tell you, I know with the Parkinson's patient, I've had several in particular that it's been very helpful and effective, but a combination of all the intervention, not just the NMES by itself. So yes, patients get deconditioned, and you'll lead to a stronger training effect if you apply the electrodes in a pattern that engages the tongue and the suprahyoid muscles to clear the laryngeal vestibule to prevent aspiration during the swallow. But I think also I should say that I would always, and I treat head and neck cancer a lot, obviously, because of the scar tissue, but there's a lot of patient populations that would benefit from NMES. One gentleman that I'm seeing right now who 19-year history of dysphagia. He had tongue-based cancer, and 3 years he was on a peg tube, but they managed to get him off. And he's been swallowing, but very difficult for years. And he came to me from a speech consult asking me to help mobilize the connective tissue, give him more range of motion in the hyolaryngeal skeleton, help seal the laryngeal vestibule with a little bit of mobility between the hyoid and the thyroid cartilage. he's so mobile now, and I've trialed some NMES on him, anticipating he's going back to the speech pathologist starting this coming Thursday. But he tells me that one of the things he wanted to swallow better was ice cream. And it was so much work for him to manage a bolus with frequent oral regurgitation and uncomfortable going out for meals. And I think with a combination of the manual care, working on his breathing and his posture, I added some NMES. I had to encourage him to shave underneath his chin, but I wanted him to feel it. That, do you feel those muscles contract? Well, that's going to make your exercise more meaningful when you're working with a speech pathologist. So there's a gamut of somebody that's 2 years or just onset with Parkinson's issues, with dysphagia, all the way through 19-year history of having difficulty in managing a swallow, that everybody can get a little better. Some patients are going to take a little longer than others, but there's a lot of things that you can do from NMES. That's, I can't give you a specific example. I'm just thinking about, don't think that because there's an article out there that discourages the use of NMES in a population like head and neck cancer because of scar tissue or missing anatomy, that it couldn't be effective. The new VitalStim Plus device has 4 channels or 8 electrodes, and that's another course that I help you guys teach on how to orient yourself with the multitude of wires that come out, and how do you time the odd channels and the even channels. And the PTs and the STs that teach that class make sense of that gadget and how it can be effective in your treatment session. But you may only decide to use one channel. There's no wrong way to do it. You just need to give it your best shot with stretching and exercise and using modalities, and the patient will improve.
Fantastic. I think you've already said this, but I'll give you a chance to say anything else if you want to. Any overarching thoughts about VitalStim and NMES, or any, pearls or thoughts you had that we haven't discussed already?
Pearls. I probably have a lot. I'm a little bit unconventional when I'm treating a patient, which you probably well know. That's just the way I do things. So if I explain something crazy, I'll probably get off on a major tangent, which are going to pull me back and say, okay, well, you should probably take the course because that's where you're going to get all the information. So the pearls, I would say, is the class has evolved from a 2.5-day class, which half a day was just learning the business of managing a program, to a really good course on not just educating yourself in the use of a modality, but in dysphagia, to now what's called the dynamic integration of electrical stimulation, or DyNES. And we are educating you with an NMES device that you can change the way current flows through the circuit. It's not just the original VitalStim device, and there are reasons why you'd want to do that. And I think the course has evolved into something that is terrific. And I think the information that you get there, it's not only VitalStim Plus or the device itself, but there's several devices that you can use now on the market that will work similarly. And so the course has evolved into, how do you use NMES in your practice, no matter what device you have, to have a more thorough therapeutic experience for the patient. So the pearl is, take the class, because the class has just been, it's been a great thing to teach. It's taught from the perspective of physical therapy and speech pathology, and it's very open. The instructors know each other really well, and I know where you need to be by the end of the class, just like the speech pathologist, and we know what questions you need to be asking, and we'll ask you the questions to get the right answers from you. So the pearl is, go to the class and enjoy yourself and ask lots of questions, and it'll benefit your patient.
All right, John, that was a good pearl. That was a good pearl. Thank you for listening. And remember, if you have an NMES success story you would like to share, contact me at craig@ciaoseminars.com. That's craig@ciaoseminars.com. We'd love to have you on the podcast. Ciao.